Dr. Bojana Jankovic Weatherly, and on this episode of the Bojana MD podcast, I'm going to be talking to Dr. Satjit Bhusri, who is a cardiologist in Manhattan. We're going to cover 3 topics related to cardiovascular disease. Number 1, topic that's often underaddressed and really not emphasized enough, mental health in the context of cardiovascular disease. Up to 40% of people with cardiovascular disease have depression, and over 50% of people with heart failure have anxiety. It's very important to address this and to make sure that there are robust plans of care for mental health in the context of cardiovascular disease. Dr. Bhusri is also going to be sharing his personal story of heart failure and how this impacted his care of patients. Number 2, we're going to be talking about menopausal hormone therapy and how this is related to cardiovascular disease, how it impacts cardiovascular disease in different ways depending on timing. And number 3, we're going to be talking about preventative approach to cardiovascular care. What types of tests are important to get, what to ask your doctor about, what sort of blood work and imaging are important, and generally when, and what are some of the risk factors that we consider when we think about that diagnostic and preventative approach. To tell you a little bit about Dr. Bhusri, he's the founder of Upper East Side Cardiology and Vein Institute, a private practice that offers comprehensive and personalized cardiac and vein care to patients in New York City. He is also a clinical assistant professor of medicine at 2 prestigious academic medical centers, New York Presbyterian Hospital, Weill Cornell, and at the Mount Sinai Hospital School of Medicine, where he educates and mentors future cardiologists. I really hope you enjoy this conversation and you'll learn from it. And now, Dr. Bhusri, if you wouldn't mind sharing with us a little bit about your personal story and how this really started to shape a different approach to patient care.
Well, thanks, Dr. Bojana, for having me on. I'm a huge follower and a huge proponent of the way you practice medicine and the way you involve functional medicine and evidence-based medicine and integrative medicine into your practice. So I find that very helpful for me, both as a provider to have a resource like you, but also to help understand my approach to cardiology as it pertains to my own personal history. As you did allude to, in about 2015, I was struck with cardiac shock and my heart stopped. I was in fulminant heart failure and was in a medically induced coma for about a month. That led to an emergent need for a heart transplant, which was unfortunately not available because I ended up going into a bacterial infection and started developing an autoimmune disease flare-up. Now, autoimmune disease is actually very prevalent in my family, and it was passed on genetically, and my sister, who's just 3 years younger, was diagnosed with lupus the same year I was diagnosed with cardiogenic shock, which was a result of an autoimmune inflammatory response that hit the muscle of my heart and causing it to stop. Now, this was, of course, after my training and becoming a cardiologist, so some may say a tragic final exam. But going through that experience as a patient, going through what patients experience in terms of the fear, in terms of the resources that you see and the barriers that you see as a patient, as also a physician, you can understand kind of where the patient is and where they are in this realm of fear or doubt or even gaslighting or just understanding why or finding an answer. Fear of the unknown was always a problem, especially in cardiology and most practices. It's easy to find an answer. It's hard to say we're working on it and to delineate. And that's very common in chronic diseases and autoimmune disease. So really, I migrated into creating my own solo practice where I focus solely on the doctor-patient relationship, face-to-face, no computers. We're completely wireless, technology-based practice, full utilization of AI, whereas there's no loss of eye contact with me and the patient, and we take our time. It's not 10 minutes. It's not, I see what blood pressure, I throw a medicine. No, we always try to answer why. And I always try to include mental health and my own personal experiences into the fears that patients have. Because look, nobody wants to come to a cardiologist, although we want everybody to come to a cardiologist because prevention is key. People usually come because a doctor told them, an ER told them, or Dr. Google told them something and they got scared. So they're coming in scared. And I understand that. And I really, I think the mind-heart relationship is so important. Just to finish off on what my little trip was in heart disease, I ended up with myocarditis, not a heart attack, but something that mimics it. Is actually called broken heart syndrome. I had a broken heart. I had what's called Takotsubo's cardiomyopathy. That's the medical terminology for the way that the heart mimics a heart attack, but it was actually a stress-induced autoimmune flare that caused my heart to stop, which puts a lot of perspective in not only the traditional way we've been taught and practicing cardiology, but also understanding how other areas of medicine influence cardiology, including the mind, including autoimmune disease, including chronic diseases.
Absolutely. Yeah. And in your case, was there also a viral infection component preceding this as well that might have activated your immune system and really kind of caused that manifestation of your background of autoimmune predisposition?
Right. So we know myocarditis has become very popular in terms of, in layman's terms, because post-COVID myocarditis was a massive increase. And basically, that is essentially what triggered my autoimmune response, was a myocarditis or a viral infection after going on a backpacking trip in Thailand, which was very hot and probably won't do again. But after coming back, I started having fevers and chills. Of course, as a cardiologist, I diagnosed myself and tried antibiotics
Probably
and
brushed it off, right?
Oh
You're
yeah,
probably
yeah.
like, oh yeah, just some virus.
Yep.
I'll get over it.
Yep. And one morning, I was spiking fevers and just was not getting better. One morning, didn't wake up. My wife at that time started CPR. I did regain consciousness, and I ended up in the emergency room of the hospital where I was the training director for students to become cardiologists.
Wow.
So when I did come to, I was in the emergency room, and my first year fellow was doing the ultrasound on my heart, and I was semi-lucid looking at him and looking at the ultrasound, watching my heart barely beating. And last I recall was yelling at him, telling him he's doing it wrong.
Oh, no way. Oh,
So,
gosh.
so during that flare up led to a condition called heparin-induced thrombocytopenia, which activated antiphospholipid antibodies, also known as anticardiolipin antibodies, which are autoimmune antibodies that reacted to the medicine that I was given and caused an influx of antibodies to attack my own body. That led to not only flare-ups of my heart and my heart failure, but blood clots in both of my legs, blood clots in my right arm that led to complete paralysis, took about a year of recovery, several surgeries, a mini event in my brain, and also a blood clot in my neck. Recovery was very, very, very hard, and it was a life event. It still is a life event. I still hold a picture of the last picture my mother took before the physicians were saying this will be his last night, and there's goals of care, and we're addressed. But survived the night, survived the week, survived 10 years now, and now I'm just paying it forward and allowing it to echo throughout our population, because it's so undermissed in not only the gender gap, but the socioeconomic gap, but there's also an age gap. Younger people are getting sicker and having heart disease sooner.
Mm-hmm. Absolutely. Yeah. Yeah. With the rise of chronic disease, rise of obesity, absolutely. We're seeing that. I'm curious, when you had that experience so you were, you had an induced coma, you were in cardiogenic shock, and this was a state that lasted about a month of being in a coma, and in this situation where your doctors were having some very serious predictions. I'm curious if you remember any of that, if you had any unusual or near death experiences or anything like that? Because people talk about this, right? And
Yes,
we don't know
frequently
how to
asked.
make
Yes.
sense of it, right? Yeah.
Yeah. Yeah. So, look, it's hard to know. I mean, it's all about. I think part of it is spirituality, whether or not you have spirituality or you believe in it, or it leads you to believe in it. I'll tell you the best experience, the best way I'm able to describe this, as I've been asked a lot about this near death experience, is Alice in Wonderland is the best way that I've been able to explain it. It almost felt like I was in the Alice in Wonderland book and show and cartoon. Um, it was a it was a hodgepodge of images and sensations of very uh, innocent and young memories all melded together, if that makes sense. That's the best way I could describe it. It was very unusual. Um, but the best way to probably explain it is, was there nothing or was there something? Okay. Well, there was no light at the end of the tunnel, but there was something. And, there are, yes, patients feel or say, I just woke up and I don't remember anything. I definitely went somewhere. And that, believe it or not, that actually helped open up my mind a little bit more after the illness to say, hey, there is some spirituality. There is something that our mind is trying to process, alleviate, maybe even heal or support during this process to let you go or come back in peace.
Yeah, yeah, right. It's interesting. It's like the way that I think about it when I hear people speaking about it and read about it is kind of like this adaptive mechanism of some sort of this is some kind of adaptation to the experience, to what physiologically is occurring. I'm curious to hear, as you started to enter the recovery process, as you started to get better and came back to consciousness and started undergoing the recovery process. Tell me about how that affected your mental health, how that affected your outset on your mindset on life.
Right. I mean, look, I was going hard and fast, just like all of us, as we are in medicine. Really, no time to breathe. Met the girl of my dreams, got married, ready to start a family, and life hits you, and screening for heart disease or screening for chronic disease or screening for possibly genetic and family history is something that I realized I neglected on myself, and I should have. And when the doctor becomes the patient, the doctor realizes that he is only human. So, yeah, mental health took a bit of a backseat in my training as a cardiologist. We kind of go more towards the hard science, but mental health ever since my illness, I would say mental health and physical health, not necessarily the actual medicines, but the mental support and the physical exercise support. Best medicine I ever had. That got my heart stronger. That saved my life. That allowed me to have a child, and it allows me to be practicing medicine today. Mental health and broken heart syndrome and autoimmune disease is all stress induced. And stress can be mental, social, occupational. It could be inflammation. It could be trauma. It could be physical trauma, mental trauma. It could be an infection. But that activates this in our population, this fight or flight, this response, this almost hyperimmune response to protect oneself. And that's kind of the protection mechanism I believe our brain has, our mind has for our body. But that can become deleterious when in current society, when we need these reactions to run away from that lion that's chasing us when there is no lion chasing us. It internalizes, it somatizes, it activates. Our body has to figure out, how do we manage these mental struggles physiologically? Because that we can understand. And that, I believe, happens with elevations in chronic diseases. So anybody who has any psychosocial or emotional stressors, guarantee you their CRP will be elevated, or ESR, because they're having an inflammation response, whether it's the mind or the body or the brain. It's always important that when I talk to patients about heart disease, there's a difference between the brain-heart connection and the mind-heart connection. There's actually direct innervation between two, and they're completely separate. The brain-heart connection makes sense. We know when we have to have our heart rate go up. We know when our pressure has to go down. We know when we're eating. The mind-heart connection, that's a bit elusive. And that's what really has to be teased out in cardiology and in my practice, especially in patients who come in with symptoms that they are very afraid of, that they're dying, that they're having a heart attack, or that palpitations are just incessant. When there's nothing organically being picked up, what do we do then? How do we tell them? We can easily discount patients and say, it's not your heart, you're okay, it's in your head, goodbye. But nobody wants that. I realized I didn't want that. I wanted to know why. And if that is, in fact, mental health, then let's take care of it. Unlike cardiology, mental health treatment takes more time. It's not that you can pop a pill and your pressure gets better. It's therapy, it's psychopharmacology if needed, but it's therapy. And that takes years, sometimes 10 years, to really start seeing good effects. And I always tell my patients, in mental health, only 50% of mental health is psychopharmacology. The other half of the equation is talk therapy. It's so important. Especially when you have life events like a heart attack or cardiac death or a family member that's experienced this, because it really echoes and scares you. And so I think, one, see your doctor, and two, doctors have to realize that the mind is so important and controls the body. We have 1 trillion cells relying on us. So what we eat, what we experience, what we feel, that's 1 trillion little guys saying, ah! So we're responsible for 1 trillion people, you could think of, in some effect.
Absolutely. Yeah. And we definitely see this two-way relationship, right? This bidirectional relationship between depression and heart disease, where one can increase the risk of the other. It's estimated that somewhere between 20 to 40% of the people with heart disease have depression, and about 30% of the people with heart failure have depression. And so I think that it's something that we learn about in our training, but then in terms of the actual implementation and talking to the patient about that, that's often unfortunately in the conventional sort of faster pace medicine, oftentimes it's neglected. And we really have to pay special attention to that, because people are affected profoundly when they have heart disease. And as you said, there's maybe kind of like this elusive, not yet explained way of that relationship between the mind and the heart. But then there are also things that we know about the vagus nerve having an impact, of course, on the heart rate variability. There are ways in which we can support the vagus nerve and being in more of that parasympathetic state, whether it's through, and I always tell people, like, there's no one size fits all. Everybody will respond differently. Some people really respond well to therapy. Some people respond well to exercise. Other people respond really well to meditation. Others to all three. And you kind of have to find what is that ideal way. And so that's why it's ideal to really work with a qualified healthcare provider who can kind of help guide people through that. And just because one modality doesn't seem to work, quote unquote, it doesn't mean we have to give up. It's just looking at, okay, what are our options? What will make the most sense in this case? But recognizing that there's this very, very strong relationship. So maybe to switch gears a little bit and talk a little bit about women and heart disease specifically, right? We know that women are protected up until menopause because they have progesterone and estrogen. And in particularly, estrogen is what's protective with respect to women on average having cardiovascular events later in life than men. But that being said, once they have events, there are actually a number of statistics showing us that their outcomes after the event are worse, and that sometimes their events even go unrecognized because, again, they're women. So statistically, we might think, okay, this is less likely to happen in a woman, or maybe they're not presenting in a typical manner. But what I really wanted to talk about is there's obviously a lot of talk in the last few years about menopausal hormone therapy, and I'm certainly prescribing it a lot more than I did in the early part of my career when everybody was kind of going by the initial WHI result interpretation, and a lot of women were denied it who really would have benefited from it. There's this idea of this timing hypothesis of how estrogen affects the cardiovascular system in women, and then there's this idea and some data supporting that if given around the time of menopause, this can actually really reduce the risk of cardiovascular disease and potentially delay it and potentially contribute to healthier arteries, more vasodilation, less plaque formation, and so on. But then if given too late after a period of estrogen deprivation, it can actually have quite the opposite effects of causing more cardiovascular events, worsening prognosis when people already have atherosclerosis or plaque. Tell me a little bit about that, and kind of how do you approach, women with heart disease or women looking to prevent heart disease, and kind of your thoughts and your interpretation of this.
Right. So this is becoming quite prevalent in our human population because the shifting age of our population, menopause is really, and perimenopause is really getting its limelight right now, and as it should. And, it was when we were in school, it was the Women's Health Initiative study that we first analyzed that really set put medicine down a rabbit hole, probably the wrong way. A lot was taken from that study, a lot because it was a powerful study. It was a study done by women nurses. It was a study that first looked at hormone replacement. So it brought with it a lot of reputation. But it also, as the years went on, we realized that a couple of things were not exactly what we thought they would be. One was the dosage of estrogen, progesterone. What dosages are needed? Two is, what are the risk factors that can lead to potential heart disease acceleration, that is accumulation of plaque and cholesterol? And the third is the idea of, does hormone replacement therapy increase risk of blood clots, or namely deep vein thrombosis in women's legs? And as we went through our education, we saw that, we found that signals show that if women over the age of 35 who have smoked cigarettes or who smoke cigarettes and are on hormone replacement, they are at increased risk of DVT. And so smoking is a major risk factor, regardless of the dosage of HRT. But the key takeaway is that HRT is safe, and HRT is helpful for women, and women suffer so much through perimenopause. And I see it so much in my practice more and more that it's important for us to start studying and really analyzing, dissecting this out, because the quality of life of half of our population, half of the people coming in, more than half of my population are women. And they are of menopause age, and their quality of life is being really affected. And this is something this is our job to heal. So going back to the studies that have resulted since that WHI study, now we're in this unusual signals of data that are showing what we call this timing paradox, and essentially saying that, okay, if you start having signs and symptoms of perimenopause, and it's still within the 10-year mark from your last menstrual period, no signs of coronary artery disease based on either some type of ischemic testing, which would be CAT scans, CAT scan calcium score stress testing, or just risk stratification. If it's less than 10 years, without those conditions, low dose progesterone and estrogen, not the high dose, but even just the low dose, not only takes care of the symptoms and helps the patient, but yes, is shown to be cardioprotective. We've learned in cardiology that estrogen is wonderful. Estrogen is so important, which is why we're always female by default. And then we become male if we have the Y chromosome, and we don't have, although men have a little bit. But the studies have shown that if you haven't started hormone replacement after 10 years from the initiation of menopause, risk of adding hormone replacement actually adds an additional risk factor for heart disease. The reason likely is, and I'm sorry, and the second indication is, I believe, over the age of 65, but please correct me.
Over the age of 60, yeah.
60, yeah. So those are the
Although
two.
It's interesting, if it's initiated before the age of 60, if it still supports quality of life, hot flashes, and so on, actually, we do tend to continue it. Of course, we have to reassess risks and whatnot,
Yeah.
but oftentimes it's actually continued even past the age of 60 if initiated early. But it shouldn't be initiated after the age of 60 or 10 years post. Yeah.
And so, it's a paradox because molecular, physiologically, it doesn't necessarily make sense. Everything in cardiology and heart disease goes back to what we call Virchow's triad. So in the blood, you have three reasons that can cause cholesterol buildup or stasis or blood clots. One is just low blood flow. Another is injury to the inner lining of your blood vessels, called your endothelium, very important lining of cells. And third is if you're on medicine or you have a pre-existing condition that causes you to be more prone to having heart disease or blood clots. So in a normal, healthy person that doesn't have any issues with their endothelium or their inner lining of their main arteries, initiating estrogen shows that it helps retain that healthiness of that inner lining. But after 10 years and not having hormone replacement, my supposition is that likely in that 10 years, you're increasing risk of heart disease. So in that 10-year graph, the curve goes up quicker in terms of your risk of developing hypertension, stiffening arteries, all the other risk factors. So when we talk about risk for cardiology, we talk about age and genetics, can't fix that, and then lifestyle. So it's 50-50, right? So we're fighting age, we're fighting genetics, and we're fighting lifestyle in that 10-year span. And, some diseases like aortic valve disease, patients who have stiff aortic valves, there's about a 2-year turnover. That means in about 2 years, it's going to get double in terms of its severity. So that kind of makes sense how those studies show. Again, it's still a paradox because understanding the pharmacokinetics as to why estrogen and progesterone can afflict the endothelium is still unsure. I suspect the second part being age is also because women over the age of 60 is a risk factor in heart disease alone. So I think we're compounding at that point. But as you aptly said in your practice, and as I do in my practice, I get a lot of clearances for hormone replacement therapy. Seldom do I tell patients that you don't qualify. More often than not, studies have shown that unless you have severe cardiovascular disease or patients who I have are called vasculopaths, very, very, very sick patients, yes, hormone replacement therapy is not an issue right now. It's not your problem right now. It's something that we need to think about, but not initiate. We have a lot more to talk about, a lot more to take care of. But that's in my rare, severe heart disease patients. I would say the majority of my cases, I say, go ahead. You know why? They're already here seeing a cardiologist. We'll just do follow-ups. We'll continue risk assessment. We'll add new biomarkers. We'll add new testing. We'll see where is your 10-year risk stand. if it's accelerating, if that risk is going up, if that 10-year risk in your Framingham score is going up, hey, we're going to have to back off or have a discussion about your hormone replacement therapy and the utilization of it and the utility of it. Almost exactly how we do when we have conversations with patients for primary prevention with statin therapy or coenzyme Q10 or even aspirin therapy now. It's always a discussion. That's the art of what we do. But a lot of it is telling patients it's okay. And a lot of it is a cardiologist telling the doctors who are prescribing that it's okay.
Yeah, absolutely. And definitely that individual risk stratification, right? Because we know in medicine, there's no one size fits all. And so really getting that lipid panel, or ideally that advanced lipid panel that can give us, maybe we can't plug it into the prevent equation or the Framingham risk score, but at the very least we can assess what are the current risk factors. We can assess, is there plaque currently that we can visualize, and then based on that make a decision, make an assessment of that risk versus benefit for the individual, right? Because there also sometimes, I think, when we think about that risk versus benefit for menopausal hormone therapy, and this of course is changing over the last few years, but I think that sometimes the benefit would kind of be not really, it's like, oh, quality of life, yeah, that doesn't matter. And all the other symptoms like hot flashes and the fact that women are losing sleep, and it's like, yeah, but that's not real. Like, this is real. And it's like, no, it all actually is very important to count when we are thinking about that risk versus benefit. I love this. Thank you so much. As kind of a closing remark, there's like so much more, but as a closing remark, I'd love to hear if you could just perhaps sum up your approach to preventative cardiology when it comes to diagnostics, just when it comes to that risk assessment piece that you generally take. Let's say a patient walks into your practice, let's say they're a 45-year-old male or female. And of course, that might be different again because of what we just talked about. But what's your general approach in terms of your testing? And I have a feeling, since we've collaborated on our care, I have a feeling I know a lot of this already, and we use some of the similar panels and whatnot. But tell us a little bit about, like, what should people that are listening to this and they are going to their doctor, what should they be asking for? At what age are you recommending coronary artery calcium scans? At what age are you recommending, that people have an LP A checked, for example, or advanced lipid panel, and those kinds of things?
Okay, so a lot to unpack. So let's start off with, in terms of primary prevention for somebody screening for heart disease. My first bifurcation is this somebody young without already pre-existing risk factors? Risk factors include you're taking medicine already for high cholesterol, diabetes, high blood pressure, you have kidney problems, you're smoking cigarettes, you're having symptoms, and family history. Now, the bifurcation actually happens in my practice at the family history. Family history is very important. In fact, history, 75% of my diagnosis just comes from zipping my mouth and just letting the patient talk, because they have a lot to say. They've been to other doctors. Maybe they've been gaslit. Maybe they've been said, this is my third opinion. I still don't know why I'm feeling these symptoms. So you let them talk it out. Most of the time, I can get the diagnosis just from that. But yes, we have some great objective tools to use. So for the young asymptomatic, family history is there, premature family history. By American Heart Association guidelines, that means a first-degree relative, so mom, dad, brother, sister, less than the age of 55 with some type of cardiovascular problem. But I extend that a little bit more because patients are living longer. Mm-hmm. So if there is a cluster in a family, or if it's not a directly first-degree relative, but maybe a second with some other phenotypic characteristics, I do absolutely love calcium scoring and CT angiograms with the calcium score, because you get two things out of that. You get anatomy and you get cholesterol. So you want to make sure they're anatomically born with the appropriate structures. And you also want to make sure, do they have coronary arteries already or not? If not, well, now we could take your cholesterol panel, right? The other part is knowing your numbers. Let's look at your cholesterol panel through the lens of somebody who doesn't have accumulation so far in their arteries. And that's a different algorithm than patients who I'm already seeing accumulation. I have young patients who have cholesterol panels you can't even measure who've already had triple bypasses because whatever cholesterol they had, it's just sticky and already starts sticking. That's genetics. That's where the cholesterol, that's where these new blood panels come in. That's where lipoprotein A or LP little a is really coming into the limelight. Yes, I think guidelines are going to start showing, and we're already suggesting in our studies that everybody should get LP little a checked at least once in their lifetime. Now, trending LP little a, what to do with LP little a in terms of its level, how to treat it, that's still about 10 years away. Yeah. What we do know is that it's a signal. It's either a yes or a no. How powerful that signal, we'll have to figure out what that portends later on. But if it's a positive, then that adds genetic risk. If it's negative, okay, we can say likely, again, this is just a data point, but it's an additional data point that helps. And these are data points that have millions of patients backed up behind it. So that LP little a, along with the new apolipoprotein B, always order those two with the traditional lipid panel. And I think the other thing that I always see, and I always want to talk about patients and the referrals are, in the lipid panel, there's a lot of independent data, not only just the LDL, not only just the HDL, but there's very interesting things and studies that have come out with millions of patients, such as looking at the total cholesterol to HDL ratio, which is seldom utilized, but has very powerful results. These are all little points that add up to putting patients into buckets and in determining what to do next. Yes, every patient gets an EKG. It's a very quick diagnostic test. And I always recommend patients getting a 3D echocardiogram of their heart and great arteries. Very non-invasive, but wow, if you see a smear, a streak, a chunk of plaque, something stiff in the heart, you're already starting to say, look, we're seeing early signs of heart disease. We're going to shift the algorithm and become more preventative in terms of treating this and attacking it now before it progresses, because it can't regress. We can only prevent it from getting worse.
Yeah, absolutely. What about tests like CPET? Do you use that to assess for endothelial dysfunction and, intervene early?
Yeah. So when we're looking at microvascular disease, we just had the Warrior trial came out 2 weeks ago at ACC, which was this idea of microvascular disease, especially in women. And angiograms were done, knowing that their epicardial arteries, or their main arteries, are clean, but they're still having signs and symptoms of heart disease, angina. Now, unfortunately, that Warrior trial showed that the traditional treatment for heart disease in patients who have microvascular disease and women with microvascular disease actually didn't show any divergence, any difference. So that's very interesting to look into. So in one regard, it shows, okay, there is no difference between microvascular disease and macrovascular disease that needs sense. But in other instances, it says, well, should there be? I mean, women die of heart disease every 80 seconds. Men die every 34 seconds. That shouldn't be true. The truth is, women also die every 34 seconds. And that's the disparity that we need to understand when it comes to microvascular disease. And so I still go for primary and secondary prevention in women with microvascular disease. I'll tell you, estrogen is great, but estrogen is a great masker. We suspect that it is estrogen that gives the subtle signs that women experience for heart disease, unlike men. And these are subtle signs of commonly just exertional intolerance or shortness of breath. I have some specific subgroups where women present with heart disease or an occluded artery. Their first sign is elevated blood pressure. And many a time it's easy to treat the blood pressure, but why is the pressure elevated, right? We could treat it, but we're not treating the blocked artery.
Right.
And so why are you short of breath? So again, it's all about answering the why. And if you don't answer the why, the patients are safe and you've done your job, but are they happy? Did you really do what we needed to do? Are they coming out saying, okay, I'm satisfied? Or are they coming out saying, I still feel this way? Like nobody can answer this,
Yeah, exactly. I think it's so important. I think people are I think it helps to attach meaning and understanding to what's going on. And I think that a lot of the patients that come to my practice, they've seen specialists, they've done their research, they want to understand, how does this apply to me? Or maybe they were gaslit in the past and, they had normal diagnostics, but something is still not right. And I think it's so important to dig deep and understand what are the causes of these manifestations that we're seeing. Yes, we should treat the manifestations, but beyond that, we should look at what's actually causing this. And I think that there's such transformation in the person's experience when there's a greater level of understanding of what's actually happening in my body and which of these things can I affect by my habits, by certain environmental exposures, and which things maybe we currently can't. And then so there's a greater level of acceptance, at least for now, of let me focus on things that I can control. Let me focus and understand the big picture.
Absolutely. And I think fear of the unknown is the worst. And I felt it, we've all felt it, either ourselves or through our family members who have really difficult diseases to put in a bucket and to diagnose and to treat and to really understand. And it's that fear of the unknown that we really need to battle. And we really need to bring back trust in our healthcare system and us as physicians, because in Manhattan, it's one of the few places where you're such super specialists that they forget about everything else. And, I could look just at the heart all day long, but if I don't look at the whole body that's connected to the heart, something's missing,
Absolutely.
Classic example, I had a patient who had left chest breast pain. And I said, look, let's make sure it's not your heart. And I said, have you gone to your doctors and mammograms and make sure your breasts are okay? And her joke was, listen, only in New York, I go to a breast specialist. She's a right breast specialist, not a left breast specialist. I go to the breast, she's a left breast specialist, not a right breast specialist. I said, I know, only New York.
Yeah,
Everybody's a specialist, but we're all doctors and we're all humans.
exactly.
And when the doctor becomes a patient, we realize that. Yeah.
Yeah, and just we realize the level of communication, between providers, and the level of communication between different members of the team is so vital, because there are going to be things that, again, I'm looking at a patient from a certain perspective of what I treat, of what I understand and specialize in. You're looking at that patient from another perspective. We're both aiming to get the full picture, but there are going to be different things that will maybe emphasize or pick up. And so it's important, which when we collaborate, that we're communicating, that the patients, it just gives me such great insight when I'm actually speaking to the specialist, when I'm speaking to the person's therapist, the person's psychiatrist, their PT, because we all come from different areas of knowledge and expertise. And I think, you can have the best specialists on board, but if they're not communicating, if they're not looking at the big picture, you're not getting the best care.
Absolutely. And as I'm sure you've seen in Manhattan doctors, we are the second opinions, third opinions, because we see the first opinions, and our job is to really, investigate a little bit deeper. And
Exactly.
That's what I hope will continue, and that's what I hope, and that's what I'm encouraged by with our collaboration in your podcast, and really to allow this to echo beyond all the noise that's happening right now as well.
Absolutely. Well, thank you so much for sharing your wisdom, your knowledge, your personal story. I so appreciate it, and I know that it'll help a lot of people. And thank you so much for your time.
Yes, thank you for having me on. Love to be on again.
All information in this video, including but not limited to the video itself, the audio, text, graphics, images, and other material contained in this video, is strictly for informational purposes only. The content is not intended to serve as or be a substitute for professional medical, pediatric, or psychiatric advice, nor is it designed to suggest any specific diagnoses or treatment. Please always seek medical advice from your physician or qualified healthcare provider regarding any medical conditions, questions, or treatment, particularly before making any changes to your healthcare regimen, medications, or lifestyle habits. Never disregard professional medical advice or delay seeking help from a healthcare provider due to something you have heard, seen, or read in this video or audio. Reliance on any information in this video or audio specifically applied to your own case is solely at your own risk.